Today I'm going to give an update on vaccination. There's been some exciting news coming out in the last couple of weeks, and I'll try to pull that all together and give you some brief notes about what are the challenges of the vaccines, the safety and the effectiveness of the vaccines, and then what is the timeline for receiving them and getting them out, and of course the priority groups. Next slide, please. So the two vaccines that we've heard the most about that we are anticipating soon are the Pfizer vaccine and the Moderna vaccine. One of the challenges, probably the most significant challenges, is that these two vaccines have different needs for temperature storage. The Pfizer vaccine requires an ultra cold storage temperature of -70 Celsius. And the Moderna vaccine requires storage in a regular freezer. So a little bit easier. They also differ in the amount of time that between the first and the second dose, which will likely present as somewhat of a challenge when administering to the population. The Pfizer vaccine is a minimum of 21 days apart for the first and second dose, and the Moderna vaccine is slightly longer, 28 days. So another challenge and an opportunity in our communication is to ensure that the public knows about the common side effects. These have been shown in clinical trials to be similar to what is experienced, say, during the flu, or I've also heard after receiving the shingles vaccination. So things like a sore arm, achy muscles and body, fatigue, etc. Next slide, please. So taking a look at the safety and the efficacy of the vaccine, there are a number of things that really do tell us that this is a safe and effective vaccine. Number one, looking at the clinical trials that were completed by Pfizer and Moderna, there were 3 clinical trials completed for each, and they were both fairly large population groups and fairly representative of our general population. The studies used the gold standard, which is a placebo-controlled and double-blinded study. So a recipient would not know whether they received the placebo vaccine or the real vaccine. And then it's also important to mention that even after the vaccine is disseminated into the community, that there will be continuing surveillance and observation of side effects and efficacy. So data will be continued to be collected. And then second of all, remembering that there were a number of independent, transparent oversight groups monitoring the clinical trials and approval of the vaccines or eventual approval. For instance, the FDA committee, known as the VRBPAC, will be the committee who reviews and potentially grants the emergency use authorization of the vaccines. The ACIP group also reviews the clinical data and recommends priority populations, which we look to for their recommendation. And then you may have heard about the Western States Scientific Safety Review, which Oregon has joined with California and Washington State. And we do have 2 physicians from Oregon who are on that group. And we do not expect that this review will delay the availability of the vaccine. Next slide, please. So here's a look at the current timeline starting in November of this year, when we did hear the results of the clinical trials from the two vaccines that are leading, Pfizer and Moderna. They did report 95 and 94.5 efficacy for those respectively. Going forth, we expect, we do know that the VRBPAC committee to potentially approve the emergency use authorization is going to be meeting in 2 days, which is very exciting. A week later, they will be meeting to discuss the application for the Moderna vaccine. And then just last week, we heard from the governor's office the first announcements for which vaccines will be arriving in Oregon and how many of each one. So here I've listed out which vaccine, how many we expect to receive. And then Oregon Health Authority has stated that they expect that all groups in the priority population of 1A will be fully vaccinated by the end of January. So let's talk a little bit more about those priority groups. Next slide, please.
Can I just interrupt here for a second, Carrie? Just because I'm
absolutely.
I just want to make sure that as members of our public watch this on YouTube later, in this timeline, when you say Pfizer, or when the slide says Pfizer second doses ship and Moderna second doses ship, you mean the second set, not that the vaccine itself, that humans have to get 2 doses, or which is it?
If I understand your question right, when it says second dose, it is the same product as the first dose, but when it says second doses, those will be intended to be administered in the population that already received the first dose.
Okay, and so that's the point of clarification that I needed, that both of these vaccines require that someone be injected twice.
Yes, and I can see how that could be misunderstood. So thank you for pointing that out. And yes.
I do have a question, if I can, since we're kind of have a couple of questions.
Sure, go ahead.
In terms of the interval, what I would be more concerned about is, you mentioned the minimum time between the dosage. What is the maximum time for that second dosage to actually be effective? Because I know there was an issue with the shingles vaccination that could be no more than, I think it was like 6 months as an example, but there was a real shortage of the vaccine, and there were concerns sometimes that people who got the first dose would not be able to get the second dose in a timely fashion. Is that going to be an issue with this vaccine?
I could see it as a potential issue in all of the information that I have read. I have never seen an indication of what the maximum number of days is, and it's very possible because of this, very short turnaround for clinical trials to be conducted, that information is just not available yet. I will do some more research, and if I find out the maximum or amount of time, I will certainly get back to you. And we are more concerned about the population who received the first dose not coming back for the second dose, because then they would not receive the maximum amount of immunity than they would if they had received both doses.
Okay, thank you.
But very good question. I'm sorry, I can't fully answer.
More to be revealed later, I guess.
Yes, I'm sure it will. Are there any other questions I can answer now? Okay, so let's take a look at these priority groups. They have been divided into 3 phases. This is a look at phase 1, where we know that we will have limited doses. We have divided this into actually the ACIP committee has divided this into phase 1A and phase 1B. So the first groups that are intended to get the vaccine will be the paid and unpaid healthcare workers who have the potential for direct or indirect exposure. We know that in that group, there are about 350,000 healthcare workers in Oregon. Also included in phase 1A are the residents and staff in long-term care facilities. And I will talk a little bit more about later, but you may have heard that the federal government has a partnership with CVS and Walgreens to fully administer vaccine to these long-term care facilities. And we do know that 100% of our skilled nursing facilities in Oregon enrolled in this program with pharmacies. We also had a very high rate for enrollment in Oregon. So phase 1B will be other essential workers, and those including teachers, food and agriculture, police, etc. And then also those who are at risk for severe illness from the disease and those who are 65 and older. So we anticipate that for the administration into these population groups, that hospitals will be the primary site for vaccination. For several reasons, manage the ultra cold storage requirement, and we want to make sure that we're maintaining that hospital workforce to deal with or to provide care to those who are hospitalized. Next slide, please. Here's a look at phase 2 and phase 3, where we will continue to get doses of vaccine and reach more and more of the population. So in phase 2, we will continue to work through vaccinating all of those groups in phase 1. And then we will be focused on critical populations who are more affected by the disease, have typically been underserved in our communities. These would include BIPOC populations, incarcerated, houseless communities, other congregate settings, uninsured, underinsured, etc. And we've listed out here where those people will typically get vaccinated. They will include places like your doctor's office, pharmacies, federally qualified health centers, which include Virginia Garcia and Neighborhood Health Center in our county. Phase 3, we will continue to vaccinate, be reaching the phase 1 populations, these critical populations, and then where many of us are located in this general population. Oregon Health Authority has said that they do believe they will have enough vaccination for everyone in Oregon to receive it by late spring. So again, what is our role? It's particularly important that we ensure access of the vaccine to at-risk and disadvantaged populations, taking a particular, focusing particularly on our BIPOC communities. Also those who have limited access to, say, a primary care provider in their healthcare system, pharmacies, or these other vaccine delivery systems that I have talked about. And then those, of course, living in poverty who generally have, would have difficulty time accessing this vaccine. We know that we will likely utilize our Medical Reserve Corps volunteers to help us administer the vaccine. And we believe that we would be vaccinating directly vaccinating a fairly small percentage of our population in the county, 10% or less, given all these other means of administration that we will be using in the county. Next slide, please. We will be coordinating very closely with our state, our regional, and our local partners. Specifically our federally qualified health centers and other community-based organizations. We will be looking to them to help us best reach out to those priority populations that I've mentioned. That's a really important relationship. We will also be working closely with our city and county emergency managers to look at potential dispensing locations spread out in areas that are ideal. For instance, I'm working closely with a City of Hillsborough planning group for the vaccine, where we're looking at potential sites for these locations. In addition, we will be working closely with OHSU on the Hillsborough Stadium testing site to also be utilized for vaccination. So this is a large drive-through site located in at the Hawks Stadium. Next slide, please. So how are we engaging with the community to really understand what concerns the community has and able to address them? We want to we believe that equity is really the major focus of our planning, and we will do that and ensuring that the BIPOC communities have access to the vaccine. We know that in the Oregon Health Authority's vaccine distribution plan, they have also set equity as the main focus for them. And we will use this as a building block, but then tailor it for our communities. We want to certainly ensure that we use our communications to address the mistrust of public health and government and the vaccine, which we know is potentially of concern. Oregon Health Authority is forming and is convening a advisory group made up of community members, where they will be looking at advising the priority groups within priority groups. So say for phase 2 and phase 3, who should be getting that vaccine first. They're also conducting a survey with community-based organizations throughout the state to advise on the distribution plan. And then we in public health here in Washington County are working closely with the Office of Equity, Inclusion, and Community Engagement to help us facilitate these conversations with our community. So with those conversations with our community, our main goal will be to listen, to understand, to help understand to help those communities understand the vaccine and also how they will access the vaccine. And we will use this communication to inform our communications plan and our targeted vaccine plan. And we have a history of having strong relationships with our community-based organizations, of course, including our federally qualified health centers, who we have partnered in the past on flu shot clinics and have valuable learnings from that. So our communications planning is underway. Our communications department will be partnering with those in the metro counties on a regional plan. And that'll, of course, be influenced by our engagement with the community and the survey data that Oregon Health Authority is collecting. We will ensure that the information we have available is in the correct languages that it needs to be. And we will use our regular weekly newsletters and our other regular communication routes that we typically use. And we will also partner with those CBOs for getting the education into their specific priority groups.